going to talk about medication reconciliation and how Lean Six Sigma put a dent in one of healthcare's toughest problems. Before we get started, I'd like to take care of just a few logistical things. If you look at the screen, you should see instructions telling you how to use your toolbar. GoToWebinar has a toolbar, and if you want to minimize that toolbar so that you can see the screen better, click on the right-facing arrow. If you want to extend that again, for example, to write a question, then you click on that arrow that becomes left-facing. This is the tool that you'll use during the presentation to let us know if you have any questions, and I'll leave plenty of time at the end of the presentation to go through those questions. We are muting you during the course of the presentation so that we'll get the very best audio quality. Today we're going to talk about the problem with medication reconciliation, and we'll summarize the results of a Six Sigma DMAIC project that was used to improve performance related to medication reconciliation. We'll describe how those results were achieved, and I'll give you a system CPI overview. Now don't worry, I'll tell you what system CPI is and what the parts of system CPI is. Then we'll suggest how you might achieve similar results at your organization. And again, my favorite part, the questions and answer session at the end of the webinar. Medication reconciliation is, without a doubt, a universal healthcare challenge. This photograph was taken at the IHI Forum in Orlando 2 years ago, so that would be the 2009 forum. They had put a large billboard-sized map outside of the exhibit hall, and they had asked conference attendees to take a red pushpin and place it in the process that they felt was most severely broken, and a silver pushpin in the process that they felt that they had improved to such an extent that it was now a best practice. Well, the medication reconciliation one is the one with the arrow pointing to it, and that was, by the end of the conference, a huge red blur. Now, at this time, this project was in the measure phase. We had already launched and completed Define. We were in measure. We were collecting data, and I'll talk to you more about that later. But I went to this conference as an exhibitor and went back to the hospital system that was working on the Six Sigma project and said, here's what we're up against, guys. Well, they were very excited about this. They said, you know, we're not alone. This is great. Medication reconciliation is the right thing to do, but how? Well, how was what I tried to find out while I was there at the conference. I asked everyone who would talk to me what they did about MedRec. And the only best practice or positive thing that I heard from anyone was one patient, one list. Hospitals and people who work in hospitals were so frustrated with medication reconciliation that one actually said that they had reverted to paper processes because they just couldn't get it right in their electronic health record. And that brings up the old don't try it in vapor till you can do it on paper, and that's what this person actually said to me. So while I talked to many, many people at the conference about how they were addressing medication reconciliation, the only hint I got at any best practice was one patient, one list. Nothing else was really a clue as to how we might improve medication reconciliation at the hospital where we were doing this project. That's, first of all, you want to see the results. Before I get into how we did it, you want to make sure that this is worth listening to. Well, here they are. We improved medication reconciliation compliance from consistently around 40% to 87%. That was immediate improvement. We know that is going to improve significantly as additional action items on the plan are implemented. We were able to reallocate 45 minutes of mostly nursing non-value-added activity for every single discharge. And at this hospital system, that adds up to about 1,800 hours per year of nursing time that can now be spent on taking care of patients. Also some other folks' time, pharmacists' time, physicians' time, but the large bulk of this was nursing time. We reduced readmissions by 28 cases per year. That doesn't sound like a lot, but when you look at these primary opportunities for medication reconciliation are in heart failure and AMI, that adds up to a lot, because now we're talking dollars. Now we're talking about reduced reimbursements, pay for performance, those kinds of things. So 28 cases per year can add up to a whole lot of money. And we knew that we would improve patient and physician satisfaction and staff satisfaction. when I show you the map, you're going to see exactly what the team saw, and they realized that everyone was running around trying to do the same multiple redundant things to make sure that medication reconciliation got done. It wasn't getting done, but everyone was doing a great deal of work trying to get it done. And then the financial results. This is going to seem phenomenal, and I'll explain something more about this later. But when this action plan is fully implemented, this project will result in $1.6 million per year in new revenues. That's a net financial benefit of $1.3 million. Now that suggests that there were some costs involved, and that's absolutely true. In order to optimize this process, there were some costs involved. But there's a story associated with that, and I'll tell you about that in a little while. Costs of implementation were primarily around software upgrades. We needed one record, one form, and in order to do that, it needed to be an electronic form. And we needed some specially trained personnel at certain points in the process. So how did medication reconciliation get from the parking lot to front and center? Well, the first 4 events, lean events, that were to be done at this facility is a large hospital system, has 2 urban hospitals, a number of county hospitals, has a lot of primary care practices, some long-term care facilities, etc. But they started with lean. When they started working with NOVACES, they focused first on lean. And there's lots of good reasons to do that. First of all, lean events are quicker. You can get them done more quickly, and that way they show a quicker return on investment. So by design, part of the deployment plan stated that the first 4 inaugural events would be lean events. The hospital wanted to add Six Sigma to their tool set, and we had already started training their Six Sigma green belts and black belts. But at the time of this project, the Medication Reconciliation DMAIC project, those folks were not in any way able to handle such a complex Six Sigma project. So I'll tell you more about that also later, but I led this project. It was my privilege to do so and had a lot of fun doing it. But how did it get from the parking lot to a fully chartered and running DMAIC? Well, CHF discharge was inaugural lean event number 1. And the parking lot is something that you do in a lean event to make sure that you keep your team focused. One of the things that the facilitator will do is put a parking lot up on the wall. And it actually is a big piece of paper with tape on it that says parking lot. And anything that comes up in the course of the team's discussion that is out of scope is put on parking lot. And the reason for that is if you don't put it somewhere and make a commitment to come back and look at that separately later, then the team can't get past it. They get stuck and they can't do the work that they've been called together to do. So the team who was working on CHF discharge recognized that medication reconciliation was one of the things that was causing them to do poorly in their core measure performance. But medication reconciliation is a Six Sigma opportunity, not a lean opportunity. So we put that in the parking lot and promised them that we would follow up on that and make sure that that didn't get lost later on. Patient transfer. Transferring patients from acute care to rehab. Once again, medication reconciliation came up as a big problem. Didn't come up in ED critical labs, but it definitely came up in ED patient holds. Medication reconciliation was a parking lot item for all 3 of those things. And that's when the leadership at the hospital system decided that they couldn't wait to address medication reconciliation until their brand new green and black belts were trained. Now here is a Pareto analysis of CHF failures just to give you an idea. The VSA was able to take all of the non-value added activity, or most of it, out of that process. But because MedRec failures were defects and related to variables that we didn't understand sufficiently enough to do anything about, we couldn't eliminate that 29.4% of failures that were due to MedRec. We could eliminate the rest, or certainly minimize those, as you'll see in a few moments. But we knew going into this that the best we could do was 70% because of MedRec. So the hospital recognized they had to do something about it right away. Now here's what the lean improvements look like. This is the CHF discharge process that I talked about a moment ago. The current state of the process, the one on the left, is the way that process was on the first day of the lean event. Lots and lots of red on this map, and red stands for waste. Lean is all about eliminating waste from processes, and red steps are waste. They're of no value to the customer. Yellow things, there are also quite a few yellow shapes in this map. Yellow things have to do with regulatory issues or business required things like coding for billing purposes. And as you know, heart failure has a lot of regulatory stuff related to it. So there's a lot of yellow, there's a lot of red, and there was those things that are steps that actually have to happen in order to deliver this valuable service to the client. The future state, the one that is on the right, that is the designed new process after the VSA, or at the end of the VSA. So you can see that the number of total steps was reduced significantly. The number of non-value-added steps was reduced hugely. The only thing that they were not able to fix here was they had not at this time fully implemented their CPOE, their computerized physician order entry, which they have now since this VSA was done implemented. So the red that you see there on the map on the right had to do with not having a fully implemented computerized physician order entry system. That has since been done, but this VSA was done a good while ago. And handoffs. Handoffs are something that in healthcare are critical, especially when you talk about medication reconciliation. The format that NOVACES uses and that I always use in a VSA is the one that you see here. It's based on a process map called a functional process map or a swim lane map, so that each horizontal section of the map relates to one function or one department or one person. And if you look at the current state map across the top, that is the physician lane. So all of those steps and decisions are the diamond shapes, all of those things occur in the physician's lane, or that means the physician is taking those steps or making those decisions. Now when we showed the outbrief in the doctor's auditorium, we had these maps made huge so that people could actually see them. The physicians were very interested in what those two red boxes were and all those lines going in and out of them. They looked like little tarantulas there. Well, those are the times during this process, during just one patient going through this process, that they are called for clarifications or corrections, or they're queried. They have to repeat something. So the physicians felt like they were being called or paged all the time, and that's exactly what this map shows. They were very, very impressed that we could reduce the number of times that they would have to be called to make corrections or clarify or for queries. So that's what a lean process VSA looks like. When we did the medication reconciliation project, we would come back to this. The problem is that medication errors are a leading cause of injury to hospitalized patients. They're a leading cause of injury, period. And MedRec is linked to adverse drug events and to poor clinical outcomes. I've worked on literally hundreds of projects looking at AMI or heart failure readmissions, and medication reconciliation is the culprit in many of those. Lots and lots of issues happen both at the admission end of a patient experience and the discharge end of a patient experience that can either go very well or can go very poorly based on how well this one process is executed. Now at this hospital, they were looking at a readmission rate for heart failure patients of about 15.4%. We knew that about 30 to 60 minutes of non-value-added effort was spent on every admission to correct medication reconciliation discrepancies. We knew that because we had done the VSA and we could extrapolate, or we thought we could extrapolate, the data from the heart failure VSA, at least in part, to get us started at least on the MedRec DMAIC. 46% of medication errors occur either at admission and discharge, and that's from the literature. We knew that going in because we looked at the literature. So we knew that admission and discharges were going to be critical places for us to focus. And as it turned out, that was exactly where the problems were. So initially, in order to charter this project, we used a core measure HF1D sample and had about 68 patients. This was in June of 2009. And we used this to create our problem statement. 29.1% of these MedRec discrepancies led, or heart failure core measure failures were due to medication reconciliation discrepancies. Anyway, we knew that this was just a proxy measure. We knew that if we dug deeper that we would find something even uglier. But in order to do that, we needed to come up with a measurement plan, which is also something that you do in Six Sigma. But the VSA alone did a pretty good job of improving this process. If you look at the statistical process control chart there on the lower left, that blue line represents the time, the separation of before VSA and after VSA. And you can see that we went right up, did very well for a couple of months, and then we had a couple of blips up and down. That's very typical of a process when you apply lean to it, but there is a Six Sigma opportunity hidden within, because the variation, that up and down motion of that line to the right of the blue dotted line, stays very, very variable, for lack of a better term. We did great. This team had been working for 2 years to improve this process, and for the first time ever, they were up into the quartile that they needed to be in for HF1D. But it was still not good enough. They needed to eliminate the root causes of MedRec defects, and that could only be done through the Six Sigma tool set. So what is System CPI? System CPI guaranteed success of a Lean Six Sigma deployment. It provides a standard roadmap, a step-by-step path to success, and here's what it looks like. 4 phases: assess, plan, apply, and sustain. And those 4 phases are done, assess and plan, very quickly. It's done in a couple of weeks, called a jump start, so that you can start realizing return on investment very quickly. And then, of course, everything that System CPI does is leading towards 2 things: sustainment and self-sufficiency. One of the things we hear from healthcare clients all the time is that we fix a lot of problems, but we're not able to sustain our improvements. So we start building in sustainment right from day one. The other thing that we build in is self-sufficiency. We know our clients don't want to be dependent on consultants forever. You want to be independent and creating this expertise organically or from within as quickly as possible. So that too is also designed in right from the beginning. An important thing about System CPI is that it's System CPI. It takes a system perspective on problems and opportunities in the organization. It utilizes all of today's most effective continuous process improvement CPI tools and methods, including Lean, Six Sigma, constraints management, etc. Of course, it is absolutely line of sight linked to strategic objectives of the organization and produces measurable results, both measurable operational results such as reduction in length of stay, reduced readmissions, reduced throughput time or turnaround time in the emergency department. Those are operational improvements, and all of those operational improvements are linked to financial returns. It's a flexible roadmap. It can be adapted to any organization, any size of organization, or any organization in any pathway along the continuum from no Lean Six Sigma experience to one who has had training. You know, they've had some work done in Lean Six Sigma, but they need to revitalize, create an infrastructure, etc. So that's what System CPI is, and that's how this deployment was created at this hospital system. Now, during that jump start period, that first 2 weeks, we look at what are the opportunities across the whole system, and we use a bunch of tools, sophisticated tools, to help figure out what are the best places for an organization to invest its initial Lean Six Sigma CPI expertise. Well, here you go. Look at the Pareto chart here. There were about half of the opportunities, 119 opportunities, I believe, were identified altogether. And of those, half of those were lean opportunities. VSA is a lean event, and an RIW is a rapid improvement workshop. That is also a lean event. So if you add the VSAs and the RIWs, you have about the same number of opportunities as DMAICs. So this hospital system knew going in that they were going to need Six Sigma. So they started training their people right away, but they didn't want to wait again until those people were trained to take on MedRec. Now here are the tool sets, the three primary tool sets on the right. Lean is all about simplifying processes, eliminating waste, and increasing speed. And when I talk about speed, it's throughput. It's moving patients, moving requisitions, moving bills through the process as efficiently as possible. It doesn't mean shortchanging those things and not giving them the attention that they need, but making sure that there are no delays and there's no rework where it has to go from step 5 back to step 2. That's what lean is all about. Six Sigma is all about reducing variation and eliminating errors, defects. And the thing that I like best about Six Sigma is the C in the DMAIC roadmap. D-M-A-I-C. C stands for control. That way you sustain the gains. You have a control plan that makes sure that whatever gains you achieve as a result of the project don't just disappear when you turn your back and you go start another project. And then constraints management is another piece of an integrated tool set. This is how do you manage constraints or bottlenecks in your processes. It helps you to focus on the system at large, the whole system, and identify where it is in that chain of events that something needs to be fixed right now. So that really helps you to focus your efforts where they'll get the most impact. And maximizing throughput, of course, is the objective. You want to be able, again, to get patients through the ED, of course, as effectively as possible, getting them the right care, but also as efficiently as possible. We in healthcare are the only industry who have designed waste into our facilities. We have waiting rooms. Lots of industries don't have those kinds of things. And in lean, waiting, any kind of waiting, is waste. So a lot of organizations go with just lean or with just Six Sigma. And that might work for a while, but if the only tool you have is a hammer, everything looks like a nail. And as we found out at this hospital system, lean did not have the tool set needed to tackle MedRec. Six Sigma takes a lot longer, and you wouldn't want to do a Six Sigma project on something that could be fixed with lean because it does take longer and therefore it costs more. There are more resources involved. So the right tool for the right problem, that gets you the right results. And this is a little algorithm that's very helpful to you. And I know this is probably difficult for you to read on your screen. So if you will contact Kevin, and you'll have his information at the end of this presentation, he'll send this presentation to you so you can see this algorithm. So projects come from 3 different sources. They can come from leadership directives, they can come from strategic planning, they can come from another process VSA. Those places where projects can come from all lead to a problem. A problem is identified. Once this problem is identified, then you ask the question, is the root cause known? If the root cause is known, then you have to ask the question, is the solution known? If the solution is known, then it's a quick hit or a just do it. If the solution is not known, then you do a rapid improvement workshop to define the solution. If the root cause is not known, like medication reconciliation, we had some assumptions, I'm sure you do too, but we weren't sure which of these many trivial X's were the critical X's for this hospital's process. In that case, Six Sigma DMAIC is the required methodology. So here's the DMAIC roadmap. Define, measure, analyze, improve, control. So define is, what is the problem? What is the pain? Measure is, how bad is it? How pervasive is it? How frequent is it? How many is it? How much is it? All of those questions are asked in the measure phase of the Six Sigma project. Analyze. Analyze the data using statistical tools. What Six Sigma does is it takes a practical problem and translates it to a statistical problem and then takes a statistical solution and translates that to a practical solution, verifying and eliminating the root causes of variation and defects. And then improve the process. Of multiple solutions, which one is the best to eliminate this problem or this pain? And then finally, control. Sustaining improvements for the long term. How do we make sure that this problem or this pain doesn't come back? That's the roadmap for Six Sigma. And I love this slide when I talk to nurses, because this is exactly like the nursing process. So Ida Jean Orlando was right. Assessment, diagnosis, planning, implementation, and evaluation is very, very much like the Six Sigma roadmap. For nurses out there, this should not be news to you. So the hospital had a decision to make. They had 2 Six Sigma Black Belt candidates. They were beginning their training, but they were a long way from being ready to handle something as difficult as MedRec. Now there's a white paper out there on our NOVACES website that I wrote some time ago, and the actual title of it is Buy One, Rent One, Grow One. And this white paper talks about the advantages and disadvantages of buying a black belt, that's hiring someone who has the expertise that you need, renting one, that's having a consultant relationship and having a consultant come in and lead these projects until your folks are ready to do that independently, or grow one. That's taking someone from within your organization and sending them off to be trained. But it takes about 10 years to become a really good Master Black Belt, so that takes a very long time. This hospital decided that they were going to rent a Master Black Belt, and they rented me. I was already working with this hospital system as their deployment mentor, so they asked me to come in and lead the Six Sigma project for medication reconciliation. Define is the first phase. I've talked a little bit about the location of this hospital system already, and the picture there really says it all. This is what our patients tend to come to the hospital with, if they come with anything at all. The champion was the Vice President of Quality and Patient Safety, and she was amazing. She did a phenomenal job of removing roadblocks for this team, and that's what a champion does. They eliminate roadblocks, and they make sure that the team is empowered to do their work. I was the Master Black Belt, and then here's the team. We had a physician hospitalist, nurse managers from the telemetry unit, a staff nurse from the same unit, clinical informatics, a pharmacy info analyst, nurse manager from the ICU, a nursing data coordinator, a core measures abstractor would become very important when we get to measure, a pharmacist, and a hospital money belt. And what a hospital money belt is, it's someone who is trained in the early phases of the deployment in how to translate operational improvements such as decreasing medication reconciliation errors to financial benefits. So we had to have someone involved because obviously this was not going to be a free project. They were paying not only for the expertise of a consultant, but the time that all these people would invest in this project. We needed to be sure we had a return on investment for it. I'm not going to read through this. You can look at this if you get this slide deck to take a look at. This is to help you figure out your own problem statement, your own goal statement, make a business case, etc. But these are the elements of a project charter, and a project charter is critical. Every Lean Six Sigma project must have a charter, and there's a standard template for it, and there are standard definitions for all of these things, and when people are trained, they learn all of this. Some more of the charter. Now look here. I put this in red because I wanted to remember to point it out to you. Earlier on I told you that the net benefits of this project were more than $1 million a year. That didn't happen until about halfway through the project. Initially, this was our estimate. Initially, we believed we could save about $252,000 per year. Or we could make $252,000 and save about $76,000. So much lower estimate initially. The charter of a Six Sigma or Lean project changes over time, and the more you learn, the more that changes. So this one actually changed in a very good way. Those metrics there are also important. For HF core measure HF1, at this time we had already implemented many of the Lean improvements. So they'd gone from the low 70s to the high 80s for a baseline. We didn't know what medication reconciliation compliance was beyond heart failure. We were using heart failure as a proxy measure. We estimated that it would be, somewhere in the neighborhood of 80%, but at that time we didn't know. And we were also looking as a secondary metric at readmission rate, which at this time was 15.4, and their goal in their strategic plan was less than 12. And their LOS, their length of stay on acute care units, their goal was 5, and they were at 7.4. So that's what a charter looks like. This is a SIPOC. A SIPOC is always used in a Lean Six Sigma event to focus the team. It helps you to see this process from a very high level. And again, I know you really can't see the words in this, and your SIPOC is going to be different than this hospital system's SIPOC. But their high-level process steps started at admission and ended at this point in the process with abstracting the record. You're going to find that changes later on. But a SIPOC focuses the team and identifies some of the potential X's and Y's related to the project. X's are causes or inputs, and Y's are outcomes or outputs from the process. In this one, a medication reconciliation defect would be the Y we were trying to prevent. Here is the process. Now, purists in Six Sigma, this process map will look very funny to you, but when we use an integrated tool set, we use lean tools that are advantageous to whatever project we're using. So I used that same swim lane functional process map format, and we did a value assessment of all these steps. Look at all the red here. Nursing was exhausted from what they were trying to do in the middle of a patient's admission. After admission and well before discharge, they were doing all kinds of things to fix admission and prevent errors on discharge. That's what all that red stuff is. 53% of the activity undertaken mostly by nursing to reconcile meds was non-value added. The process was full of workarounds, having to go back and do something over again, or doing something over again just in case. Lots and lots of multiple redundancies. Every time there was an error, a new process was added, a new checkpoint was added. Night nurses on the night shift were auditing every single chart for medication reconciliation. Every single chart. And then that would have to be sent back for rework, and lots of redundancy. Everyone involved in this process was working excruciatingly hard, but the process was severely broken, as you can see here. CTQs are critical to quality characteristics, and one of the things you do in Six Sigma is you ask your customers, what is important to you? We knew, based on feedback from patients and families, that they didn't want any adverse drug events, and they wanted to understand their discharge med instructions. They wanted medication accuracy and safety. So we took that need, that issue, and we translated that to CTQs. The providers wanted medication information that is correct and there when they need it. The hospital wanted 100% in their core measure performance to reduce their readmission rate at a minimum resources. And of course the interdisciplinary care team just wanted to take care of people. They wanted to do it as effectively and as efficiently as possible without all this redundancy and rework. The define phase, that's the first, the D in the Six Sigma DMAIC roadmap. We of course did a stakeholder analysis. Remember, change management is a part of every phase of system CPI. And we looked at all of the stakeholders related to medication reconciliation. We came up with a detailed communication plan so that everyone would know what was being done and why and what was in it for them and what the results might be. And this is happening on this day. Communication is critical, especially early on in a deployment, because people are a little bit leery of new things happening in their workplace. The complexity of the process map, we didn't need to look any further to know that simplification was a #1 concern. This process had to be simplified. So we used a best tool for the job approach, and we used some lean tools in addition to the classic Six Sigma tools in order to simplify this process and to hone in on where these medication reconciliation errors were occurring. This reinforces the value of a comprehensive tool set. It provided all these newly trained lean experts, is what they called their green belts, opportunities to look at lean in action while they were participating in a Six Sigma project. And it allowed us to create a functional process map that illustrated those handoffs, which we know from the research is where medication reconciliation errors occur. So it was very useful to use this integrated tool set during the define phase. Now, realizing that IHI had identified MedRec as one of healthcare's toughest problems, the team was both energized and incentivized by that, but it was also a cause for concern. They were a little bit worried that maybe their scope was too broad, but we moved forward. And we did a fishbone. This is an Ishikawa or fishbone diagram that was used to brainstorm and capture all of the potential causes of MedRec discrepancies. Well, the ones in red are those that the team felt were significant X's. So they're highlighted in red because, for example, the team thought that patients who were admitted through the ED had more MedRec errors than patients admitted from other sources. Okay, we'll look at that. It doesn't mean that we're going to assume that's the case, quite the contrary. It means that we're going to collect data to validate that that is indeed a cause. And you'll see the results of that here in a moment. We had to have a sampling and data collection plan. We couldn't use heart failure as a proxy measure and get the rigor that we needed for a Six Sigma project. So we looked at what sample size we would need for a statistically valid sample according to the rules of Six Sigma, and we would need 326 charts. This required a chart audit. That's why HIM was so important on the team. 326 charts at 40 minutes a chart, that would take a very long time. So we met with the champion and we came up with 101. She was willing to live with a 9.5 MOE so that 101 charts could be audited, not 326. And there's a summary of the measurement plan there at the bottom. And when you're doing Six Sigma projects in healthcare, measure phase takes a long time. And the reason measure phase takes a long time is because you must pass a measurement system analysis to make sure that your measurement system is actually giving you data that's statistically valid and reliable. So we had to create a measurement system and then test it to make sure that it was rigorous enough for Six Sigma. Based on the information that we collected, here are some of the results. If you look at the Pareto analysis of MedRec failures, you can look at that by patient care unit, you can look at that by admission, and look at there. This Pareto chart on the upper right seems to validate the team's idea that patients admitted from the ED were more likely to have a medication reconciliation error. However, that was not the case, and we proved that statistically. But we knew it looking at this, because if we took the sources of admissions, that proportion is almost exactly the same as MedRec failures. So MedRec failures were not happening any more frequently in patients admitted from the ED than those admitted from home or from the nursing home. It's just that they were admitting more patients from the ED. So it made it look like or feel like that was a significant X. We would disprove that later on. And then whether they were discharged to home, this is a great example. Right here it looks like, wow, people going home, if you didn't go any further in your statistical analysis, were where we should focus our resources. But be careful. That's where most patients are discharged. So the conclusion is here, the Paretos were not very helpful, and MedRec was a process that was universally broken. So we did our data collection. It took longer than we hoped, of course, and here's what we learned. Our percent yield was 40%. That's a process sigma of minus 0.253. Minus 0.253. We needed a Six Sigma result for a best practice benchmark process. 600,000 defects per million opportunities. So we estimated initially that we thought MedRec might be about 70% across the organization. No, it was 40%. Only 40% of the time was a patient's stay in the hospital without a medication reconciliation error. And then there's some additional statistics there on the right. The most startling of those is that many, 37% of MedRec failures had more than one MedRec discrepancy. So we knew we had a big problem on our hands. Here's a summary of the measure phase. I think I've covered all of these. 30 minutes per chart was the mean. It did take a lot of time to collect this data. We had to come up with a reasonable sampling plan based on confidence in the cost of data collection. And then, of course, it took longer because we had to create this plan, test it, and then launch it. One of the things that really worked well that I didn't mention from an earlier slide is we used the definitions from heart failure. So the abstractors were used to those definitions. We just applied them to all patients in the hospital, all types of patients. So we would have a real measure of MedRec capacity or capability all across the organization. I talked about this already. This is what a transfer function looks like. And here are some of the potential X's. Admitting unit, disposition destination, patient care unit, admitting nurse. I didn't say anything when they said that, but I was a little concerned there. Discharging nurse, also a little bit concerned there. And which step in the process? The number of prescribing providers, that was thought to be a sure hit, a sure thing. Therapeutic interchange was also thought to be a reason that MedRec errors occurred, whether they were inpatients or outpatients. Now, initially, we were told that there were no medication reconciliation errors in the outpatient population. As it turns out, the proportion was exactly the same. Whether or not there was a resident involved in the care, this is a teaching hospital, was thought to be a predictor of a medication reconciliation error. I'll show you the stats on that in just a moment. The number of home meds, we knew from the literature that the number of home meds is associated with medication reconciliation errors, but we tested that ourselves. And there were some high-risk meds. We tested those as well. So all of these trivial X's were distinguished from the critical X's, those X's that were having an impact on MedRec failure using chi-square and regression analysis. And as it says there at the bottom, there were, as always, some surprises. Here is a summary of our hypothesis testing. Now the p-value is what tells you, based on statistical tests, whether or not this variable, this factor, has an impact on the y that you're measuring. So do these factors tested in the second column impact medication reconciliation? And if the p-value is less than 0.05, then you can assume statistically that yes, it does absolutely have an impact. So number of home meds definitely had an impact. Definitely had an impact. But the number of physician providers did not. Where they were dispositioned to did not. Where they were admitted from did not. Whether or not a resident was involved in their care did not. One huge aha was the statistical chance of a medication reconciliation error occurring when there was a hospitalist on the case was 0. The p-value here was actually 0. So that was a huge clue that we would follow up further in our analysis to what the future state or the improved process needed to be. And then, of course, we learned that inpatient and outpatient status did not make a difference. So, critical X's identified through statistical analysis were complexity. We knew that. We could see that. We didn't have to count it. But absolutely complexity was an issue. Multiple redundancies and stopgap measures, critical to fix those. A lack of clear ownership and accountability. There wasn't a captain of the ship. Lots of different people were trying to do the same thing without the information that they needed all over the place. There were significant measurement gaps. The hospital, the team, they knew a lot about MedRec. They'd had a team working on this for a very long time, and they estimated 70%. They were stunned when they found out that the capability of their process to prevent a MedRec error was only 40%. Number of home meds, we validated that statistically, and this hospital oversight thing. What does the hospitalist do that's different? And we had to go out and find out. There were some findings that were expected based on benchmarks like the high-risk meds and the number of home meds, but there were those that were surprises. In general, it were process, not people factors. And when I say hospitalist was a significant X, I mean the process that the hospitalists used to assess and care for patients in the hospital was different. That's the only people factor that we found that was impactful. And the hospitalist, of course, on the team was very, very happy that his p-value was 0. One of the things we did to figure out what was the most important improvement is called a quality function deployment. This is a classic Lean Six Sigma tool, and we did some benchmarks at some of the folks that you see there, but our process redesign priorities were based on our statistical analysis and our benchmarks, and they're there in that Pareto diagram on the right. We needed one list, we needed a captain of the ship, we needed a doctor entry of the discharge so that the physicians were consistently doing the same thing all the time. We needed an admission RN or a pharmacy tech to do the admission med rec. We knew we needed some special expertise up front. The nurse needed to be independent in their med rec activities, and then those other things, those are grouping meds by category, they all had to do with the form in their electronic health record. Here's the future state. Now you'll notice there are still some red things in here. A future state is what you think you can achieve in about a 6-month period. That we knew there were some things that it would take longer than 6 months to fix. But if we implemented the action plan that the team drew up based on our analysis, this is what we felt we could achieve within a 6-month period. So there would be 2 functional roles added. You can see there are 2 extra swim lanes now. But redundant activities were eliminated, and non-value-added activity waste was reduced from 53 to 9%. Huge improvement lean-wise. More to come. So in order to achieve a future state, we have a plan of action and milestones. It's based on an old tool called the Pew solution selection matrix, and it's used to prioritize solutions based on some criteria. So we divided those up into 4 categories, and quick hit improvements were done right then. And then there were 5 rapid improvement workshops chartered to develop the more complex and more important improvements. One was all around the role and the competencies of an admission med-rec specialist. What does this person need to know? What do they need to be? Are they a nurse? Are they a pharmacy tech? Can they be one or the other? This team had to get together and define that. And then developing the criteria for one of the most important improvements, which was the complex medication profile. We knew that if we implemented this new process for all patients across the hospital, we would be wasting resources. And in the interest of lean, we wanted to focus this new and improved process only on those patients who needed it. So this team would develop the criteria for the complex med profile. Those patients are the ones who would be followed from admission through discharge to their next point of care using the new process. One form, one paper and electronic form for med-rec. One of the problems was that there were multiple forms in multiple places. So we had to work with the software developer of their electronic health record to get one form that would be as good on the screen as when it is printed, because people will inevitably print these things. So it needed to be one electronic and paper form. And then we had to define the role of the discharge pharmacist. For those high-risk patients, those complex med profile patients, a discharge pharmacist review was critical. And then, of course, defining all of those specifications for any systems, EHR changes and enhancements, making sure that all of the changes that the team needed done in the health record and their other systems was done appropriately, communicating that stuff to the software vendors. Key improvements. Here are the criteria for complex med profile. High-risk meds such as Coumadin, heparin, insulin, DIG. Greater than 10 home meds. We looked at the research, of course, and we saw a couple of numbers out there, but based on our statistical analysis, 10 was the right one. The medication list unknown at admission. If the patient is admitted and they don't know, or their family member doesn't know what medications they're taking, they immediately become a complex med profile patient. Any patients with a diminished level of consciousness absolutely become a complex med profile patient. And patients with end organ failure. Those patients met the criteria for complex med profile, and they were then assessed and monitored by a medication reconciliation specialist who is specially trained either as an RN or a pharmacy tech to do medication reconciliation. One form we talked about, and then the discharge med lists of patients who meet the criteria are reviewed by the discharge pharmacist prior to discharge. And providers utilize the hospitalist approach to med-rec. And when we went out and interviewed the hospitalists and documented their process from other physicians, primary care physicians, consulting physicians, specialists, specialty providers, surgeons. What we found out was that hospitalists don't assume that they know what meds the patient is taking. So they start with a blank slate. They don't think, oh, I put that patient on this Celebrex 2 years ago, and assume that they're still taking Celebrex or that they ever took Celebrex. Hospitalists assume that they don't know anything about the meds that the patient is taking, and that is the best approach with medication reconciliation. Assume you don't know. Here's a summary of the action plan. I won't go through this. There are lots of specific things in here that you can take a look at when you get the slide deck. We've already talked about the high-level ones, but there were parts of admission, clarification, system things, and some discharge things that had to be changed. And of course, because medication reconciliation touches the patient, we had to do a test of change. The first test of change was a very narrow scope, only 14 patients, and we learned a lot from this. We had some issues. We had to go back and tweak the action plan a little bit, but we got some great feedback from the staff, and one of them is there at the bottom. This nurse came to me afterward and said, "This is the first time a committee," she called us a committee, but that's okay, "has ever done anything that actually makes it easier for the nurse to take care of patients." And as a nurse, I was thrilled to hear that. Then we did a big test of change. This was on very busy units, lots and lots of patients who met the the complex med profile criteria. Census was expected to be very high, and here is the result. It was incredible. We went from 40% to 87%. Process sigma, we're still a long way from 6, but 1.13 is a lot better than minus 0.253. So we were thrilled at this point that we had found the right combination of improvements to change this process. However, at this point, we hit a roadblock. Leadership was convinced that the new process would work, but it would cost too much. So they were challenged to find a low-cost solution that did not require any additional resources. This team was deflated. They were discouraged. They were so upset. But we got together, and they decided they were going to hold their ground and convince management that this was the right solution to this problem. And as a result of them getting together, we used some TREES tools, and TREES is a process improvement methodology from Russia. TREES stands for Theory of Innovative Problem Solving, and TOC, that's constraint management that I talked about earlier. We used some of those more sophisticated tools to solve the contradiction. Need to spend money to save money. And through this, a brilliant idea was born. It was actually the hospitalist and the director of the hospital pharmacy who came up with this idea. They had a brand new outpatient pharmacy across the hospital, across the street from the hospital. And it wasn't getting the traffic that they were hoping that it would. But they had pharmacy staff there waiting for business. So this team decided that they could, if the discharge hospitalist reviewed those medications when the patient was ready for discharge from the hospital and filled those prescriptions for those patients, that would result in a net return on investment, $1.3 million per year. So that required quite a bit of changing the way people thought, communication, reworking how that outpatient pharmacy was really going to be used, but that got us the approval that we needed. Hospital leadership said, absolutely, we'll take a phased implementation. It began early this year. The budget was approved, and this process has been implemented, is still being implemented. The last phases of it are being implemented, and medication reconciliation at this hospital is no longer the problem that it once was. So we tested, developed, and refined the improvements. Some were easy, some were not. Keys to success: a dedicated physician champion, an energized and enthusiastic team, rock-solid data and statistical analysis, the team's persistence in the face of pushback from executive leadership, support and involvement of key stakeholders, especially this director of pharmacy, and finding new revenues to more than offset the costs. Next steps were a phased implementation. They have hired these folks. They're implementing these processes, these process improvements right now, and are well into their third test of implementation phase. So very, very good work going on. And they're replicating these improvements at their other hospitals, so that's great. Questions? I haven't left as much time for questions as I hope to. But I will open this up to Kevin now. Kevin, what kind of questions do we have from our listeners?
Thanks, Vicki. Hi. We have several questions. Some are similar. The first question was, how important is it to get finance involved, and then what's the best way to get them to go about this?
Very, very important. That money belt slide that I showed early on, if I had more time to talk about that, I would have. It's critical to get finance involved early on. You have to, at the beginning of every project or event, estimate what your financial return will be. Obviously, if a hospital or a healthcare system or any organization is going to invest in Lean Six Sigma, CPI, whatever you want to call it, they need to see a return on investment pretty quickly because there's no free money out there these days. So getting finance involved early on so that they understand that they will be translating operational improvements to financial improvements is critical. And making sure that every charter is reviewed by the money belt or someone from finance so that they know when it comes time to say, yeah, we did a great project on medication reconciliation. We saved $1.3 million. Imagine if that had never been reviewed by finance. They would have laughed us all the way out of the building. So you have to have them involved up front so that the calculations make sense when it comes time to validate or prove that the project saved as much as it did. Great question. Thank you for that.
Sure. Another few that came up here that are similar is, what should someone look for when thinking about hiring a black belt from the outside to help them with a MedRec project such as this?
First of all, it's healthcare experience, real healthcare experience. People who don't understand healthcare will have a very difficult time understanding why patients don't just come to the hospital with their list of medicines, or why you can't just call the pharmacy and find out what medicines these patients are taking. You have to be someone who understands that we're dealing with the most variable of all variables, patients. Not only are they people, they're sick people. They're people who are in pain. They're people with diminished level of consciousness. You have to have an understanding and appreciation for healthcare and able to be able to address this. And then, of course, you absolutely must have the statistical or the technical tools to do this, because this was a complex one. We had to use some pretty sophisticated statistical tools to validate which metrics were the most important. There were simply too many to fix them all. Great question. Thanks.
And I guess one more here. A couple people asked, does NOVACES offer one-day executive workshops to explain system CPI and how it would impact their specific hospital?
NOVACES offers a wide range of things, and that is one of them. We can do demonstration projects. If you go to the website, and I'll show you some contact information here in just a second, and then if I forget, Kevin, remind me to move the slide. Go to our website. We've got lots of white papers out there. I'll show you a few of those in a moment. We have lots and lots of ways we can introduce CPI, Lean Six Sigma, whatever you want to call it, to your organization. And it can start with a single session with your executive leadership team. It can start with a demonstration project. All different ways of doing it, whatever is best and most appropriate for your organization.
Right. And I guess the last one here, I'll just do, how do they get the doctors involved and stay involved in these types of projects?
Well, the hospitalist that I talked about is only one example, even from this particular hospital, where the key to this is getting them involved. And that's also the hardest thing, to get them involved. But once you get physicians involved and they see the results, they will be your best supporters. They will be those people who stand up for you like this hospitalist did and said, hey, wait a minute, this team used this methodology to come up with the best solution. This is the best solution, and we need to figure out a way of doing this. He was only one of many physicians at this hospital who became great supporters of Lean Six Sigma. In fact, there was one physician, he was the medical director in the emergency department, who had had a bad experience with what he called Six Sigma. Didn't really sound like Six Sigma, but some kind of process improvement methodology in the past. And he was adamantly opposed to any more people tinkering around in his ED. Well, of course, when you start working on something like patient holds, you're going to end up in the ED. And he became such a believer that he led multiple projects. Before I finished my work with this hospital system and left, He was leading multiple projects independently in the emergency department. So physicians can become your greatest supporters, but you need to prove it. You need to have good data because they'll smell bad data a mile away, and you need to use the statistical tools that they're used to seeing in their professional journals and things. They will recognize and appreciate that. Getting them involved and then using rock-solid statistics and disciplined approaches.
Great. Thank you very much, Vicki. That pretty much wraps up the questions.
All right, good. I've put up there on the screen the NOVACES website and some of our white papers. And then I'll show you the last slide is, whoops, this is me. Here's my contact information. Or you can contact Kevin directly. And our deployment leader is Dan Chauncey. And he is at dchauncey@novaces.com, and he is the one who designs the jump starts and those kinds of things. But if you'll go to our website, you'll find everything that you need to know to take the next step.
Great. Thank you, Vicki.
You're welcome. Thanks, everyone, for joining us today. Best of luck with MedRec.